Good evening, everyone present here. So, more aspirants will be joining us soon, but we can start the class now. So, today topic is rheumatoid arthritis, and the speaker that we have here is Dr. Susobhan Mondal, who is consultant internal medicine and rheumatology in Apollo Multispeciality Hospital, Kolkata. Doctor, you may take over.
Thank you. So, good evening, everybody. I am Dr. Susobhan Mondal. Am I audible?
Yes, sir.
Okay, thank you. First of all, I want to appreciate for what Farz Academy is doing for or supporting for membership and other degree aspirants. Today, our subject or topic of discussion is rheumatoid arthritis, uh, which is a huge topic, I think, but I will try to make it understandable in half an hour or something like that. So, mm, uh, can you see my screen?
Yes, it
Hello.
is visible.
Yes, sir.
Oh, okay. Thank you. So, for rheumatoid arthritis, we all know that it is a symmetrical inflammatory arthritis affecting men and women. Women more, 2:1 ratio, and the age group of mainly 40 to 60 years. And this is the criteria uh, for diagnosing rheumatoid arthritis. This is the latest criteria all which is followed worldwide. This is 2010 ACR Euler criteria. So this criteria includes joint involvement and serology, that is rheumatoid factor and ACPA, anti-citrullinated peptide antibody, and acute phase reactants, CRP and ASR, and duration of symptoms. The total score is 10, but if we add joint involvement, serology, acute phase reactants, and duration of symptoms, and the score is, if it is more than equal to 6, then we can diagnose it as rheumatoid arthritis. So, uh, this is the newer version. Previously, before 2010, rheumatologists used to use the 1987 criteria, and this criteria is better. And for the MCQs, the last duration of symptoms, that less than 6 weeks and more than 6 weeks, this is the point for MCQ. In
Sir,
MCQ,
excuse
will
me.
yes, please.
I'm Dr. Arijit from ICU, Tata Medical
Okay,
Center.
okay,
Sir, your voice can be a little bit louder.
okay. Thank you. Is it audible now?
Yes, fine. Thank you, sir.
Okay, okay. So for the MCQ aspirants, for the MCQ, the last point, duration of symptoms, that is less than 6 weeks or more than 6 weeks, this point is very important. In MCQs, it is often come like this, that this is this criteria is not included in 2010 ACR Euler criteria, and they will give 4 weeks, and that will be the answer. That is not included. It is actually 6 weeks. So I want to highlight this for the MCQ purpose. And this criteria actually aimed at classification of newly presenting patients. In addition, I want to tell you that if the patient come with long-standing disease, including those whose disease is inactive, maybe with or without treatment, we have to go to backwards. And retrospectively, we have to collect this data. And if retrospectively collected data gives us more than 6 points, then we can diagnose it as rheumatoid arthritis. And here are some points which I should elaborate, like there are some points like large joints. So which are the large joints we should include? The large joints actually refer the shoulder, elbow joints, hip joints, knee joints, and ankles. These are the large joints. Remember that the wrist joint is not a large joint. Wrist joint.
जिसका बनाना
Hello. Okay. Remember that wrist joint is not a large joint. Wrist joint is not included in the large joint. And also, the small joint refers to the metacarpophalangeal joints, proximal interphalangeal joints, second to fifth metatarsophalangeal joints, thumb interphalangeal joint, and wrists. Wrists is included in small joints. Distal interphalangeal joint, first metacarpophalangeal joint, and first metatarsophalangeal joints are not included. You have to also remember this, that distal interphalangeal joints, DIPs, first carpometacarpal
Sir,
joint.
cannot hear your voice again.
You can't
Very
hear me.
interruption is going on.
I don't know
I
why.
can hear, but
Okay.
interruption is going on.
Can
Your
you hear
voice
me
is being
now?
cut.
Can you hear me now?
So I believe there must be some network issue. Susobhan sir, you are audible. I would request Dr. Arijit sir to please check his network once.
Cutting.
My network is full.
Yes, sir, you may continue.
Okay. Please tell me if you can't hear me. Okay. So where are we? Yes, large joints and small joints. And remember that DIP, distal interphalangeal joints, first carpometacarpal joint, and first metatarsophalangeal joints are excluded from the assessment. And that the point in the joint involvement, there is more than one point is that should be more than 10 joints, and at least one small joint should be involved, and that scores 5. Can you see that? That there is a point that more than 10 joints. Yes, that point includes one small joint. That point must include one small joint, and other joints may be temporomandibular, acromioclavicular, or sternoclavicular. So
So can you
this is
please
the
repeat which joints are excluded from the diagnostic criteria?
yes, the joints that are excluded are distal interphalangeal joints, DIPs, and first carpometacarpal joint, and first metatarsophalangeal joints. These 3 joints are excluded. Okay.
Okay, sir.
Okay. So in this, the distal interphalangeal, remember also that distal interphalangeal joint actually is involved in osteoarthritis and psoriatic arthritis. Distal interphalangeal joint is most commonly involved in osteoarthritis and psoriatic arthritis, but it is very, very rarely involved in rheumatoid arthritis. So if a patient, if there any question comes like that, if a patient is having distal DIP joint swelling, don't answer rheumatoid arthritis. That will be absolutely no. The answer must be osteoarthritis or psoriatic arthritis or anything other else. Okay. So this is the criteria. And what is the difference between 2010 and 1987 criteria? First, synovitis was redefined in this criteria in 2010 criteria as active synovitis in at least one joint that cannot be better explained by another diagnosis. So what are the other diagnoses that we can think, like psoriatic arthritis, gout, or osteoarthritis? Secondly, the positivity for ACPAs, that is anti-phthalate peptide antibodies, and the abnormal levels of ESR and CRP were added in this criteria. Both ACPA and CRP did not exist in 1987. And thirdly, the morning stiffness, rheumatoid nodules, and erosions or periarticular osteopenia on radiographs that was part of in 1987 criteria were excluded in this new criteria. This morning stiffness, this point is very important. In MCQ, they will give this point, morning stiffness, in which is not included in 2010 criteria, and they will include morning stiffness, and that will be the answer. And this criteria works very well if we compare with sensitivity and specificity with 1987 criteria. Actually, in this criteria, the rheumatologists actually want to catch the newly diagnosed RA patients, new patients. And 1987 criteria were more of established rheumatoid patients because those rheumatoid nodules, erosions that actually happen after a long duration of the disease without much effective
Excuse
treatment.
me. Sir, excuse me. Sorry for
Yes,
interruption.
yes.
Sir, your voice can be a little louder. Again, I can hear because I'm not carrying the headphone. It is
Okay.
very.
Rest of the students, can they hear me? Rest of the doctors,
Yes, sir,
can
we
they
can
hear?
hear you.
I think there is some network issue for.
You are absolutely
Excuse
clear,
me.
so it's not an issue. We can hear you
Okay.
clearly. Thank
So we can go to the next slide then. Factors contributing to rheumatoid arthritis. Cigarette smoking. This is the most important modifiable risk factor and remains the strongest known environmental risk factor for rheumatoid arthritis. If somebody smokes cigarette, then he or she has chance of 1.5 times of having rheumatoid arthritis than normal people. And carrying RA risk alleles in the HLA shared epitope, the strongest genetic risk factor for RA. Now, if we combine this HLA-AC, that sharing epitopes, along with cigarette smoking, if a person smokes cigarette and he has that HLA shared epitope for rheumatoid arthritis, then he will have 20 times more chance of having this arthritis than normal people with cigarette smoking and presence of this epitope. And interestingly, alcohol consumption in moderation may lower the risk for developing RA, particularly anti-CCP positive or ACPA positive RA. Potential associations with infectious agents have been observed, although the data are often conflicting. Early menopause was associated with an increased risk of subsequent development of RA. If we this is actually patients often come with this hand. The other patients will come in your chamber for consultation with this type of hand. This is the most common hand of patients with RA. Is this the right hand? It actually shows, we can easily see that the swelling of the metacarpophalangeal and proximal interphalangeal joints. Swelling of the proximal interphalangeal joints is typical of RA, this proximal interphalangeal joints. And this second metacarpophalangeal joint. This proximal and second metacarpophalangeal joint swelling is typical of RA. And this will actually is associated with morning stiffness, which is not included in the criteria. And the patient will have difficulty in making fist, and the patient will have reduced grip strength, and there will be, of course, tenderness on the affected joints. And this is the 4-point technique for palpating the small joints of the hands. This is actually for the PSS examinees when if they are given a RA patient, then they have to examine the joints like this 4-point technique for palpating the small joints. Just take a look in this picture. This is very easy actually. And we can go to the next slide. And this is how you palpate the metacarpophalangeal joint. This is the palpation of the dorsal and volar aspect of the MCP joints. Okay, this is how you should examine. And also, rheumatoid arthritis patients come with trigger finger. They will tell you that my finger, I can't extend my finger, and that makes a snap sound when I extend my finger. That is trigger finger. Actually, the flexor tendons for the finger that pass through the A1 pulley, there is A1 pulley near the palmar surface of the MCP joint, metacarpophalangeal joint, and the thickening or nodularity may prevent the flexor tendon from sliding smoothly through the pulley, and that will result in snapping sensation while flexing or extending the finger. So this is trigger finger. It's like pulling through a trigger of a gun. This trigger finger. And we all know, we are all familiar with this picture. This is Bertonary and Swannick deformity. We all are familiar. These also come in the Mrcp exam, these pictures. This is very common picture actually. Just look at the first PIP joint, and if it is flexed, then it is Bertonary, and if it is extended, then it is Swannick, along with the DIP joints, the reverse extension or flexion of the DIP joint. This is very common, and this is also a picture of rheumatoid hand, and this is there we can see a flail thumb. The thumb is flail in the right hand, and note that also there is subluxation of the fifth metacarpophalangeal joint of right hand, and there is also prominent ulnar styloid, and there is, of course, we can see that ulnar drift is there. This ulnar drift is also important for exam purpose.
So can you
Yes.
there is network problem I missed.
I can't hear. Yes, please. There is the ulnar drift, and there is a flail thumb in the right hand. We can see the flail thumb and the ulnar drift, and also the subluxation of the fifth metacarpophalangeal joint. And we can see the prominent ulnar styloid also, right? Okay. The next one, this is actually a picture of extensor tenosynovitis. Extensor tenosynovitis of a patient of rheumatoid arthritis. In spine, the spine involvement in rheumatoid arthritis is limited mostly to the cervical spine, particularly the upper portion of the cervical spine. And then in this X-ray, we can see that ADI means Atlanto-dense interval. This is the interval between the C1 and dense. This distance here it is 14 millimeter, and more than 3.5 millimeter in adults is considered unstable. This is important. If this question actually comes in SCE, not in MRCP, but also you should know that ADI, this ADI distance, if it is more than 3.5 millimeter, then it is considered unstable. And if it is more than 10 millimeter, that it indicates the surgery is needed. And here it is 14 millimeter. And that SSC, that is space available for the cord. SSC is space available for the cord, or also it is termed as posterior atlantodense interval, PADI. This is actually, we want that it should be more than 14, 1/4. But here it is 9 millimeter. If it is less than 14 millimeter, then it is associated with increased risk of neurological injury, and also it is an indication of surgery. So for ADI, we want it to be more than 3.5 to be unstable. So we want it more to be less than 3.5. And for PADI or SSE, we want it to be more than 14. So please remember this. This is important. ADI and PADI. And this is, we all actually have, maybe it is very common condition. This is actually a case of rupture of popliteal cyst. In case of popliteal cyst rupture, we often see that bluish discoloration in the ankle, both sides of the ankle. And in later stages, we will see the purple discoloration at the back of the knee in the popliteal fossa, and this is a very important differential diagnosis is DVT. So we must do a Doppler study to rule out DVT in case of popliteal cyst rupture. And the differential diagnosis for RA can be like this. There may be viral infections, that is post-viral arthritis, parvovirus B19, hepatitis B and C, chikungunya, polymyalgia rheumatica, palindromic rheumatism, RS3PE, that is remitting seronegative symmetric synovitis with pitting edema, adult onset Still's disease, SLE, multicentric reticulohistiocytosis, crystalline arthritis, and spondyloarthropathy. These all are differentials we should think of. And these are the extra-articular manifestations of rheumatoid arthritis. This pericarditis, pruritus, vasculitis, felty, scleritis, episcleritis, glomerulonephritis, amyloidosis, secondary Sjogren's, pulmonary fibrosis, bronchiolitis obliterans, and rheumatoid nodules. These are the extraarticular common manifestation. But the commonest extraarticular eye manifestation is keratoconjunctivitis thicca. We should remember this. The commonest eye manifestation is keratoconjunctivitis thicca, not episcleritis or scleritis. They also come in MCQ. Now, if we see the survival rates of patients with extraarticular manifestations of RA, we can clearly see that blue line, that the survival rate of with extraarticular manifestation is decline or decreasing with extraarticular manifestations. So extraarticular manifestation is very bad for a patient with RA. And this is an extraarticular manifestation. This is, we can see that rheumatoid nodules in the PIPs. There is rheumatoid nodules. And this is the biopsy of a rheumatoid nodule. In the central portion, we can see the fibrinoid necrosis in the central portion. And this is surrounded by the histiocytes. And the most outer layer is the fibrosing connective tissue. This is the biopsy of a rheumatoid nodule. This also come in MCQs. That a patient comes with this type of nodule and biopsy shows like this. What is the diagnosis? The diagnosis is rheumatoid nodule. And what is this? This is neutrophilic dermatosis of Sweet syndrome. This is very unusual, rare extraarticular manifestation of rheumatoid arthritis. I want to show you the picture. Then this can come also in MCQs. This is the actually picture of Sweet syndrome, neutrophilic dermatosis. That is an extraarticular manifestation of RA. Now, Felty syndrome, very, very important for question. Felty syndrome is defined as RA in combination with splenomegaly and neutropenia. Absolute neutrophil count should be less than 2000 per microliter. The syndrome characteristically occurs in patients with long-standing seropositive nodular deforming RA. The MAC locus is HLA-DRB 10401. These all are important for MCQs. And the treatment strategy for Felty is methotrexate, glucocorticoid, GCSF, and splenectomy. But in patients, this is the most important line here. There are patients with refractory Felty syndrome, use of biologic DMARDs like rituximab is suggested as potential second-line therapy. The question will come like this, that all these have failed. What is the next option? The answer will be rituximab for Felty syndrome. And also, this is very important. This is the risk for the development of lymphoproliferative and other malignancies is increased in patients with RA, particularly in those with Felty syndrome, as part of the large granular lymphocyte leukemia LGL spectrum. A variant of Felty syndrome has been described in patients who have neutropenia and large granular lymphocytosis in blood and bone marrow. This picture often comes in exam. What is the diagnosis? The diagnosis is LGL, large granular lymphocytic leukemia. Although this is not a rapidly progressive malignancy, and decreased survival is unusual. And these cells are actually cytotoxic T cells. Parenchymal pulmonary nodules are generally asymptomatic and found in seropositive patients with widespread synovitis, and usually they have rheumatoid nodules elsewhere. So if a patient comes with rheumatoid nodules, there may be other extra-articular manifestations also. So nodules heralds bad prognosis. Rheumatoid nodules always herald bad prognosis. The pulmonary nodules tend to be peripheral in location and can measure less than 1 centimeter or up to 6 to 8 centimeter in diameter. They can cavitate and cause pleural effusions, pneumothorax, bronchopleural fistulas, hemoptysis, and infection. Pathologic examination of the nodules reveal a central necrotic zone surrounded by a cellular area of proliferating fibroblasts. The differential diagnosis of pulmonary rheumatoid nodules include neoplasms, tuberculosis, and fungal infections. In case of solitary rheumatoid nodule in the lung, excisional biopsy may be necessary to confirm the diagnosis. This is important line. What will you do? You will do a excisional biopsy. Always we have to exclude the other diagnosis like neoplasm. Pulmonary nodulosis and pneumoconiosis in patients with RA, that is Kaplan syndrome, are characterized by several nodules greater than 1 centimeter in diameter scattered through the peripheral lung field. This Kaplan syndrome actually occurs in who has exposure with coal, silica, or asbestos. This is very, very rare, Kaplan syndrome, and that do not happen now. This occur very rarely with individuals, and they need extensive exposure to all these coal, silica, and asbestos. In patients with RA, ILD, this ILD generally takes the form of NSIP or non-specific interstitial pneumonitis or usual interstitial pneumonitis, UIP. The two types of ILD can happen in RA, NSIP or UIP. UIP is more pleural based, subpleural based, and NSIP is patchy. And in NSIP, we'll find more GGOs in NSIP, but not in UIP. And UIP has worse prognosis. Glucocorticoids have been a mainstay of treatment of active progressive RA-ILD. Therapies such as mycophenolate mofetil, azathioprine, or rituximab are sometimes also used. But benefits of immunosuppressive therapies are unclear in many cases. Two antifibrotic agents, pirfenidone and nintedanib, have been approved for the treatment of idiopathic pulmonary fibrosis and may have utility in RA-ILD. Although drug-related acute toxicity is possible, neither methotrexate nor TNF-alpha inhibitors appear to promote chronic progressive lung injury in RA. Sometimes rheumatologists, we actually confused that if we should introduce methotrexate in case of RA-ILD. If there is good lung function with PFT, if we see the lung function is good, then we can actually introduce methotrexate. And recent data suggests that we can give methotrexate in RA-ILD if the patient has good lung function. Rheumatoid arthritis is itself an independent risk factor for coronary artery disease. When we actually diagnose a patient of rheumatoid arthritis, he or she has 3 times more chance of coronary artery disease than a normal person, age and sex matched. And pericarditis is the most common cardiac manifestation of RA. And I said earlier that the most common ocular involvement is keratoconjunctivitis sicca. This is the most important line here. MCQs come from this line. The most common ocular involvement is keratoconjunctivitis sicca. And episcleritis usually correlates with the activity of RA. And the process, which may be either nodular or diffuse, develops acutely and causes eye redness and pain. If a patient of RA comes with eye redness and pain, episcleritis is the first differential. And small vessel vasculitis is intimately associated with many of the clinical manifestations seen in RA. But vasculitis is always there, but it is some indolent basically. And subclinical vasculitis is always there and very common in RA. And renal involvement is rare. This is a picture of episcleritis. Episcleritis looks like this. And this is a good table that the comorbidity for RA and what should we do with that comorbidity, what measure should we take. If the patient has coronary artery disease or stroke, minimize the use of NSAIDs and glucocorticoids in RA. If the patient had history of venous thromboembolism, we should be very cautious about JAK inhibitors like tofacitinib, which is very widely used now. We should be very cautious if the patient has any risk factor for VTE or has history of VTE. If the patient had prior malignancy, that may influence use of biologics or targeted therapies. And for malignancy, the first choice biologic therapy should be rituximab. And if the patient has diabetes, we all know that we should avoid glucocorticoid. And if the patient has osteoporosis, we should avoid glucocorticoid. If the patient has depression, we should select SNRI. And if the patient has history of diverticulitis, it is also important for MCQ. If the patient has history of diverticulitis, we should be very cautious about IL-6 receptor antagonists like tocilizumab. So for diverticulitis, we should not use IL-6 or antagonists. And if the patient has peptic ulcer disease, we should minimize the use of NSAIDs and glucocorticoids. And if the patient has chronic kidney disease, we should minimize the use of NSAIDs. We all know that. Next slide. So about treatment of rheumatoid arthritis, if we start it early, the prognosis is very good. Earlier the treatment, prognosis is better. If we see this graph, then we can easily see that early intervention is so good for RA patients. And target to treat strategy for RA patients. The target to treat strategy, the first study for target to treat strategy was done through TICORA study, which actually showed that improved clinical response, function, quality of life, and radiography progression in 18-month follow-up with target to treat therapy, T2T therapy. That ACR 70, that is 70% remission is so much more than the routine therapy with intensive target to treat therapy. Treat to target approach for a patient with conventional synthetic DMARD naive RA. So what will we do? We first diagnose RA and then we start methotrexate with short-term glucocorticoids. And we can also use leflunomide or sulfasalazine as per choice or after seeing the contraindication. If more than 50% improvement in disease activity by scoring, then we will continue the same treatment. If no, then we have to check for prognostic factors. That is, joint, if there is presence of joint erosion, if there is any history of cigarette smoking, if the disease duration is much more than 6 months. Uh, there is high CRP and ESR initially. These are all poor prognostic factors. If these factors are present, then we have to add a biological or TS DMARD. If prognostic factors are absent, then we can change the DMARD. So this is how we actually, in general, we actually treat the RA patients initially. Now, for patients with methotrexate inadequate response, SARS, this triple therapy is non-inferior to etanercept, the first study, RACAT 15. Triple therapy, that is methotrexate, sulfasalazine, and hydroxychloroquine, is non-inferior to etanercept plus methotrexate. So if we give etanercept to these patients, then that will not much help for the patients except for the cost. The cost of etanercept is high. For methotrexate, next, for methotrexate IRs, that is inadequate response to methotrexate, there is non-inferiority of abatacept versus adalimumab. This is ample study. Then methotrexate inadequate response, tocilizumab is superior to adalimumab. That IL-6 receptor antagonist tocilizumab is superior to adalimumab, and also we should recollect that we should not give tocilizumab for patients with history of diverticulitis. We have to recollect that this is the actually for MCQs. So if a patient is failed with adalimumab, next choice will be tocilizumab. And for methotrexate inadequate responders, tofacitinib plus methotrexate is non-inferior to adalimumab plus methotrexate. We have to add methotrexate with tofacitinib because tofacitinib monotherapy did not meet non-inferiority criteria against either tofacitinib plus methotrexate or adalimumab plus methotrexate. Did not meet. Tofacitinib alone did not meet the non-inferiority criteria. So if we actually prescribe tofacitinib, then we have to also add methotrexate to it. And next, for methotrexate inadequate responders, upadacitinib plus methotrexate is superior to adalimumab. First, we see that tofacitinib plus methotrexate is non-inferior to adalimumab, but upadacitinib plus methotrexate is superior to adalimumab plus methotrexate. So if MCQ comes that a patient with who was taking adalimumab and methotrexate and has failed, then what would be the next choice? If they give tofacitinib and upadacitinib, you must answer upadacitinib. And for CS DMARDs inadequate sponsors, rituximab is non-inferior to TNF inhibitors. This trial is very well known, Orbit 30. The rituximab is non-inferior to TNF inhibitors. And the last, the methotrexate inadequate sponsors, the sialimumab superior to adalimumab. As measured, this is Monarch 26. So from here, the message is that if they give tofacitinib and upadacitinib in MCQs, we have to take the upadacitinib. And some important info here, very, very important. Patients receiving rituximab, baseline immunoglobulins are recommended prior to initiation. IG, we have to see IgA, IgG, and IgM. And patient receiving tocilizumab, a baseline lipid profile is recommended prior to initiation. If abnormal, lipid lowering treatment should be initiated. For tocilizumab, we have to see lipid profile. This is also very common in MCQs. for screening for TB before starting a biologic. All patients require screening for TB before starting a biologic. Screening for TB should include checking for previous TB exposure and treatment, performing a clinical examination, chest X-ray, and either a MANTU or an IGRA, that is interferon gamma release assay, or both as appropriate. For patients on immunosuppressive therapy with a normal chest X-ray, as the patient was on immunosuppressive therapy, a MANTU will not be helpful. So we have to do quantiferon TB gold assay. And patients with an abnormal chest X-ray, previous history of TB or TB treatment should be referred to a specialist with an interest in TB prior to commencing a biologic. And immunocompromised patients screened for latent TB with an IGRA alone or together with a MANTU and found to have a positive result in either test should be considered for treatment prior to starting biologic therapy. For immunocompromised patients, if either of TB gamma gold or MANTU is positive, we have to start TB treatment prior to biologic. Patients should be treated with prophylactic anti-TB treatment prior to commencing a biologic then. And therapy may be recommended. This is very important for MCQs, that therapy may be recommended after completing at least 1 month of anti-TB treatment, and patients should be monitored every 3 months. So therapy may be commenced after completing of at least 1 month if the patient has any latent TB. And for active TB, therapy should be given for 3 months. That is the last point. Patient with evidence of active TB, they should be given at least 3 months of anti-TB treatment before we can commence biologic treatment. For latent TB, after 1 month we can give biologic, and for active TB, after 3 months we can give biologic. Very, very important. Patients should be screened for hepatitis B and C also, and who are HIV positive, a risk-benefit assessment should be undertaken with consultation with hepatologist, and caution should be exercised in the use of biologics in patients with previous malignancy, as we have already discussed that in that case, rituximab is the biologic of choice for any malignancy. And pre-existing ILD is not a specific contraindication for biologic therapy. In that case, if ILD is there, rituximab or abatacept may be considered as first-line biologic if ILD is there. And this box is very, very important for MCQs. This box that upadacitinib actually inhibits JAK1, filgotinib JAK1, and tofacitinib JAK1 and 3. Baricitinib JAK1, 2. This is very important box. Next, pregnancy. Which drug we can continue in pregnancy and which drug we can't continue? This is the recommendations of British Society for Rheumatology. And we can see that methotrexate should be stopped more than 1 month preconception. This is the very important. We should stop methotrexate 1 month before preconception. And this is absolutely no for pregnancy, methotrexate. And next is leflunomide. Leflunomide is absolutely no for pregnancy. We will come with that later. Very important for exam purpose, this methotrexate and leflunomide. For pregnancy, all the other drugs can be continued like azathioprine, sulfasalazine, tacrolimus, etc. And for mycophenolate, we have to stop 6 weeks prior to preconception. So for methotrexate, we have to stop 4 weeks preconception, and for mycophenolate mofetil, we have to stop 6 weeks preconception. And all the biologics can be continued conditionally in pregnancy, like infliximab, etanercept, adalimumab, sartolizumab, and golimumab. The most pregnancy-friendly biologic is sartolizumab. You please uh, mark that sartolizumab is the most pregnancy-friendly biologic. And for JAK inhibitors like tofacitinib or upadacitinib, we have to stop 2 weeks pre-conception. So these three are very important for MCQs or exam purpose, that methotrexate, mycophenolate, and JAK inhibitors. Methotrexate 4 weeks, mycophenolate 6 weeks, and JAK inhibitors 2 weeks. And leflunomide is absolutely no. This is here we come with leflunomide. Leflunomide is contraindicated in pregnancy and should not be given to women of childbearing age unless suitable contraception is used. Female patients generally require a 2-year drug-free washout period before conception to allow full elimination of the drug. The alternative is to give cholestyramine or activated charcoal washout 3 months before conception to measure the serum active metabolite of leflunomide, which should be below 0.02 milligram per liter, measured on 2 occasions and 14 days apart before conception. So after washout, we have to measure the leflunomide 2 occasions, 14 days apart, 3 months before conception. And the washout regime as per British Society for Rheumatology guideline is either cholestyramine 8 gram KDS for 11 days or activated charcoal 50 gram QDS for 11 days. This leflunomide small note is very important for exam purpose. Okay, so here we end our topic today. Thank you.
Thank you, sir, for being with us. It was a really nice session. So, I would like to ask all the aspirants if they have any question regarding the topic, you may ask now.
Excuse me, I'm Dr. Ghoshal or Jitesh Ghoshal. I have one question. Now,
Yes.
you have one very important part, which I feel is the diagnostic part, the marker. My
Yes.
question is the anti-CCP in rheumatoid arthritis, can it be negative in selected cases?
Yes.
Please
Yes. Yes. Of
enlighten us.
course. Of course, it can be negative. And if we see the ACR criteria, either RAF or anti-CCP should be positive. RAF can be positive or anti-CCP, either one of them can be positive, and we can diagnose it as rheumatoid arthritis if if we follow the ACR criteria.
No, my question is, can it be negative?
Yes,
And
it can
in a case
negative.
of
It can be negative. It can be negative in rheumatoid arthritis because
what is the percentage?
uh, it can be negative because all the antibodies against this hydrogenated protein, we don't have the machinery to detect all the antibodies yet. So in
Right.
that case, it can be negative.
And regarding the scleritis and the episcleritis,
Yes.
which one is more common, the episcleritis or the
Episcleritis is
scleritis?
more common. Episcleritis is more common, but the commonest is keratoconjunctivitis theta,
Keratoconjunctivitis.
and next is episcleritis. If a patient comes with redness, pain in eye, most common condition will be episcleritis in case of rheumatoid arthritis.
And regarding the radiological findings, earlier the periarticular osteopenia was given importance, but the recent criteria they are not giving it.
Yes,
So
yes,
then,
right.
then what is the imaging? Can you please point the imaging gold standards?
Yes, it is very good question. Very good question. From the we actually imaging is not needed for diagnosing rheumatoid arthritis. But if we can image the X-ray, actually it does not help in diagnosing. But if we can image like X-ray, the periarticular osteopenia is the first sign of rheumatoid arthritis, periarticular osteopenia. And
Right.
for synovitis, I think to detect synovitis, powered Doppler ultrasound is very useful tool now, and also very that Euler Umaret scoring. Please note
Okay.
that Euler Umaret scoring for the synovitis purpose is very important for exam purpose. Euler Umaret scoring. That scoring actually involve the synovial hypertrophy and the circulation. Hmm.
And regarding the HLA markers in rheumatoid arthritis, are they effective?
Yeah, not yet. Not yet. Actually, research is going on hugely, and the machinery is not yet there to detect all the HLAs.
Okay. Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you.
Good night.
Sir, one question.
Yes.
Yeah. If once positive, they will be remain positive lifelong. That anti-CCP antibody and RA factor.
No, there can be negative. They can be negative later on.
So if a patient come later, what will be the diagnostic criteria?
Yes. Actually, I told it in my short lecture that we have to go back and we have to take history. We have to go back and we have to take history. And from history, we have to do the ACR scoring.
Thank you, sir.
Okay.
Any more questions? So I believe
I
there are
think
no
there is.
question
Okay.
anymore.
Okay.
So
Okay. Thank
thank
you so much. Thank you.